Mr. Jones, my name is Steve. I'm going to be your nurse today. Can you verify your name and birthday for me? Alright, thank you. So the doctor would like to put an NG tube in. Just checked his order in the computer. And the NG tube is a tube that goes in through your nose and down your esophagus into your stomach and allows us to give you food and medicine without having you chew it up orally. I think that's going to be better for you. So is the doctor, just with the condition you're in right now. So I'm going to put your bed up, and then we're going to get started on that. I'm going to raise you up and then put the head of your bed up as well. So I've verified the physician's orders, gather my supplies, provide the patient privacy, and wash my hands. I've also assessed that Mr. Jones is able to cooperate and help me with the procedure. Alright, Mr. Jones, we're going to listen for bowel sounds real quick, make sure everything's moving. So we can put this in. It's going to assess which areas is more patent. And for a gag reflex, the right nares is most patent, and there is a gag reflex present. Your bowel sounds in all 4 quadrants, and so we will proceed putting that in. Alright, I'm going to place this across your chest, just in case anything comes up. And here's a cup of water. So as I put this in, I'm going to have you extend your head backwards up against the pillow, and that'll help it go in a little better. And then once I get started, I'm going to have you press your chin to your chest and swallow for me. Okay, so I'll get some tape ready to secure the tube. To inspect the tube for any flaws or kinks, make sure everything is present and looks good. Okay, and then I'm going to measure from the tip of the nose to his earlobe and then down to his process. And I'm going to mark that with a piece of tape. I'm going to lubricate 4 to 5 inches of the tip of this catheter, or this tube. Alright, if any time you're really uncomfortable, just raise your left hand for me. Otherwise, it's just going to be a little uncomfortable going down, and then we'll be all set. Okay? So I'm going to extend your head backwards against your pillow. Here's your water. Here's a towel if you need it. I'm going to have you put your chin to your chest and swallow for me real quick. Slip this in here. Okay, I'm going to go until we reach the piece of tape that I placed. I'm going to secure this patient's face so that it doesn't pull out any farther, going any deeper. Make sure that the tube is not touching any piece of the nares. That can irritate patients. Okay, now we're going to check the tube placement. A couple different ways. We're going to aspirate gastric contents, 10 cc's gastric contents. Let's put it in our cup and test for a pH that is proper for the stomach acid. And we're also going to insert 30 cc's of air into the tube. Also assess the patient's ability to speak, swallow, and talk. And we will have it verified by a chest x-ray before we give any medications or feedings. Okay, once we've verified the placement, we're going to secure it to the patient's gown, a safety pin, and make sure that this is staying up on the patient's face. We then document that the procedure is done, the patient's tolerance, and the length of the tube from the tip of his nose to the piece of tape to the end, and put that all in the documentation. I can then drop the patient at the head of the bed to 30 degrees or mid-Fowler's position, as is comfortable for the patient. Then place him in a low position, and we'll provide mouth care every 2 to 4 hours as needed for the patient, and continue to assess for bowel function. Alright, once once placement is verified and the doctor wants to give a feeding, we'll come back, and Mr. Jones, could you verify your birthday for me and your name? Thank you. The doctor has verified the placement with the chest x-ray, and he would like to give you a tube feeding. So we're going to get you some food with the tube. So I'm going to sit you up just a little bit and we'll get going with that. So I've gotten feeding and verified this is the proper one from the doctor, checked the expiration date, and brought it to room temperature, which will be best for the patient. First thing we're going to do is again assess the placement of the tube with pH. Test that with a gastric burp as well, with 30 cc's of air, listening to the epigastric region. And then also we verified with the chest x-ray, and we'll also be assessing if the patient is continuing to be able to speak and breathe easily. Once we've done that, we will draw the gastric contents, aspirate that, and assess the amount of it. Here we only had 30 cc's, and so we will draw it back up and put it back. If it is over 150 milliliters, then we'll need to inform the doctor and hold the feed. For this one, since it was only 30, we're going to continue with that. We'll then flush with 30 cc's of water, and then we will proceed with the feeding after we've auscultated for bowel sounds and done the rest of the checks needed. So we'll keep the feed going at a steady pace, but not too fast, where it would cause cramps for the patient. Okay, once that is complete, I'd like to flush with 30 cc's of water to clear the tube. Then clamp the tube, cap it. Ensure that it's still secured to the patient's face and gown. Continue to provide mouth care every 2 to 4 hours, and we'll document the feeding and patient's tolerance of the feeding, and continue to assess for bowel movement and activity as the day goes on. I'll then clean up my supplies, remove my gloves, wash my hands, and make sure that the patient's bed is in a low position and no lower than mid-Fowler's position for at least an hour.